Two of us.
Okay, I'll try. You're on.
I'm on.
Yeah.
I'm on where?
9 seconds went real fast. Sorry, guys.
Hello, everybody. Welcome to Fertility Fact or Fiction. I am your host, Dr. Rahi Victory, a double board certified reproductive endocrinology and infertility specialist. And we have the best show on infertility on the web, hands down, no questions asked, with loads and loads of people to watch from all across the world every week, getting their questions answered. And I did promise this week that I would talk about dual triggers, but I didn't have time to put it together. So I apologize. We will not be talking about dual triggers other than to say everybody already knows that dual triggers are best, but it's still widely underused. However, Fertility and Sterility will be now publishing the article that showed that it's better to use a dual trigger. And so that should be up and coming any day now. So we're kind of excited about that. If you are watching us on TikTok, hopefully TikTok will not tell us that we're not a real show like it has been recently, because you're watching us on the phone and hopefully the sound quality is good, and we'll see how things go. So great to have you all with us again. We have some exciting upcoming shows with some people that want to kind of join us on the show, more like the podcast type of approach. We'll be reviewing some new articles that are coming out, and I'm going to a conference tomorrow, so I'll bring back any new tidbits that I learn to share with you guys. Yeah. And I think otherwise we're going to be taking questions tonight. Not a whole lot of new in the fertility world, so we'll give you guys answers to more questions hopefully tonight, because there's not a lot that's really come out or happened. We are starting to do more of the whole genome sequencing cases. So if anyone out there is struggling with recurrent implantation failure, recurrent pregnancy losses, you should definitely reach out to us, because we have new testing that is not very available to everybody yet. And that testing is incredibly robust at being able to determine if you have a gene that would potentially prevent you from being able to ever be successful. And so this is something we're doing more and more of now, being able to help people that we were never able to help before, because now we can at least get them answers and guide their future care, which has been very, very powerful and robust and helping us in ways we never imagined possible before. Also had a great chat with a colleague from way out west today, who is more than happy to send us his patients who have been struggling for implantation. And so we'll be helping even more people than we ever have before from out west. And so that's kind of an interesting new add-on for what we do. Some of the immune therapies, and their clinic is actually willing to sort of listen to what we say, which is not always the case. So I'm really excited about that opportunity. Yeah. So it's Tariq Ibrahim from Ibrahim Strategies Group, my buddy.
Bonjour.
Fellow car fanatic. We were just watching a show on the new Corvette ZR1.
Looks serious.
It does look very cool. And no, our wives will not allow either one of us to get one.
I'm still getting punished for the first one.
Yeah, I got yelled at. I got to build a deck in the backyard.
Oh, you have some chores to do now. There's some responsibility.
Oh yeah,
up.
there's a lot. The house is getting done. The chores are getting done. Everything. So
that's my life right now.
Yeah.
You know, Father's Day is coming, so I assume that this is my chance to like do nothing and just, reap the rewards.
Yeah, that's for one day, dude.
That's no, but I was thinking I'm kind of like building up to it.
Yeah, I know.
So this is like the month of honoring my amazing husband.
Yeah,
no, it's not.
There's no amazing husband going on.
There's no one amazing in that whole house. Let me tell you.
Oh, other big news. My daughter is home for the summer, and we'll probably try and get her on the show.
Well, that'd be great.
Yeah, we'll talk to her about being a medical student and why she wants to do infertility, aside from the fact that her old man does it. So yeah, Jenna will be on with us probably
Good reason to do it.
Probably next week, actually, if she's up for it. Yeah.
Okay, great.
Yeah.
All right, first question.
Yeah.
Hi, docs. Dr. Amy says PRP technique is key. She uses a spinal needle and believes her approach gives better outcomes than meta-analysis data. Where and how did you learn your technique? Continued, what needle guidance injection methods do you use? And do you track outcomes? If so, which?
I love Dr. Amy. We're friends. Unless she's doing it abdominally, I'm not sure how she's doing it with a spinal needle because they're not long enough. And you can't use ultrasound guidance at the same time. So we actually just do a reverse IVF injection. So we do it like we're doing an IVF egg retrieval, but we just stick the needle directly into the ovary and then we flush the PRP in. So I agree that the technique is important. However, I can't imagine anyone doing it better than we are because this is the best visualization that you have. The other problem with using a spinal needle is that PRP is pretty viscous. It's hard to get through. So you'd be like cranking on the needle to inject it in. And you're probably going through an abdominal approach. If you're using a spinal needle, I don't know why you would do that. So no, we don't do it that way. We do it with a transvaginal ultrasound guided needle guide, super safe. I'll never do anything unsafe. So that way we're really careful. Yeah.
Next, hey doctors. Unexplained infertility, one failed FET, fertility came back normal, expects negative LAD. How many lit sessions would you typically recommend?
Well, we always start with 2 sessions of lit, and then if it's insufficient, we'll do more. But typically speaking, 2 sessions of lit is enough for about 70 to 80% of our patients to convert. For the ones that don't, we either try more lit with them or we do donor lit. So any of those are viable options. But we do it 2 and we do it a month apart, and we've had very good results with that.
Question from Instagram. Almost 6 weeks pregnant, and I hardly have any symptoms except for sore boobs in the morning. But I'm on prednisone for RPL. Could prednisone be dulling my symptoms?
Yeah, absolutely it could, because prednisone comes with its own symptoms. And so it will mask some of your endocrinologically mediated symptoms that you get from pregnancy. A lot of the pregnancy symptoms have to do with the rapidity of the rise in estrogen. And so there probably will be some blunting of that if you're on testosterone, or on prednisone. So yeah, for sure it'll have an impact.
Dr. VNT. Well, thank you for acknowledging. A summertime question, even better. If expecting FET in early fall, should I limit swimming in public pools or clean local lakes to protect my microbiome that I'm working to improve?
No, the vaginal mucosa is actually what we call coapted. So it closes when you're in a pool or when you're swimming. So it's pretty uncommon for women to get a lot of pool water into the vagina while they're swimming, unless you're diving in sort of feet first, legs wide apart, which I don't recommend. And same thing in a lake. So no, there wouldn't be a reason. The other thing is that while the vaginal microbiome is very important, the uterine one is probably even more important. You're clearly not going to get any lake water in there, or pool water for that matter. So no, you can happily swim lake or pool and be safe.
I didn't guess that was going to be the answer.
Yeah, it'd be totally fine.
Totally fine.
Yeah.
Hi, doctors. When do you start Plaquenil and tacrolimus for an embryo transfer in a patient with immune issues and endo? Thank you.
So it depends on how bad their endo and or their immune issues are. This was actually a topic of conversation here today. We've currently been doing it based on severity, but we might move to just starting everyone a month in advance, which is probably what we're going to do moving forward. But, some cases we started a week or 2 in advance. Other cases we started a month in advance. So it just depended on how bad the case was. Like severe endo or sky high cytokines, we'd start earlier. Not so bad, it was mild, or the cytokines weren't so bad, we'd start, closer to the stem of the FET. So we've varied it, but I think we're just going to standardize it and do it a month in advance. And this was something I was talking to our clinical practice lead, the amazing Sarah Hilliard, today. So she will probably be formalizing that for our protocols moving forwards.
Question from TikTok that still is a-okay.
It's still happy with
It's still
us.
happy. Yeah, it likes us today.
Yeah.
Do you recommend Fertility before every FET? About to have my first transfer of euploid embryos. No endo.
No, we only recommend Fertility for people with a history of failures, people who have very few embryos, or people that are just like sort of psychologically, emotionally traumatized by this process, and they only want to do it once. So anything where you need to optimize your outcomes, absolutely, it's very reasonable. Or if you've had a history of complications, failures, miscarriages, implantation failures, and so on, yes. The other group where I offer it, but I really don't push it, is unexplained infertility, because some people don't want to do IVF. They'll do the Fertility, they'll find out what's wrong, we fix it, and lots of those patients actually get pregnant. I just had one the other day who had a microbiome disorder. We fixed it and she got pregnant. So it's good for unexplained infertility. It's good for previous miscarriages, recurrent implantation failures. And it's great if you don't have a lot of embryos or you just don't want to have to go through this more than once.
Another one from TikTok. Would APS and positive lupus anticoagulant cause 4 miscarriages at 5 weeks? Was on ASA and Lovenox.
Could it? Yes. Would it if you were on aspirin and Lovenox? That's less likely. I actually haven't had a lot of failures on aspirin and Lovenox, so I would actually strongly consider having an evaluation. So contact us and we will tell you kind of what tests you need, because it's unlikely that by itself is the only source of your miscarriages. I would want to know things like, does your partner smoke? Does your partner have obesity? Did he take the right vitamins? Is he using, the right approach to improving sperm quality? How often does he ejaculate, and so on? And then from your end of things, smoking, drinking, drug use, what's your body mass index? What's the egg quality like? What vitamins are you on? What's the shape of your uterus? I just put out a post the other day where a patient actually, I had said, I need 3D images of your saline infusion sonohysterogram. She didn't have that, but she sent me pictures of her hysterosalpingogram. And this is someone that had hysteroscopy already. Someone had been inside her uterus with an operative scope looking around and said she was fine. And you can tell, like an imbecile could tell that wasn't fine. It was an incredibly T-shaped uterus, and that needs correction. And when I told her, she said, how could no one have told me this? I was like, honestly, I don't even have an answer at this point. Like, obviously somebody should have noticed that that's a very T-shaped uterus. So there are subtleties that often get missed because I don't know why. I don't even want to speculate on the because, but there are subtleties that get missed. And so because of that, we always recommend a thorough evaluation. And so if you have miscarriages just because of APS, antiphospholipid syndrome, and you've done the treatment for it, which is aspirin and heparin, and it's not working, I would want to know what else is wrong. And there can be subtle things that we can find. And I'll tell you, like, I find some of this stuff within minutes of talking to people and no one's ever told them before. Simple things, tuberculosis history, like a lot of patients from the East will have a history of TB. And if they do, it makes it incredibly difficult to get them pregnant. People with abnormal uteri, people with microbiome problems. We get loads of people that had, retained tissue for a while, and then they finally got it taken out a month later or whatever. No one ever checked their microbiome. In advance, those people have bacteria just entrenched in the wall of the uterus that you're not going to get rid of very easily. So that's something we have to deal with. So there are subtle things that if you're thinking about it and you're twigged to it, you'll be able to answer. Endo being a big one. I'm sure you guys saw the post I put out today about endo. Like, I just operated on someone and they got pregnant. So that's the way we want it to be. We want it to be educational options, find out what you can do, and then do whatever you need to do to give yourself the best chance.
Is an AMH of 1 minus Is IVF even possible?
1 minus? I don't even know what that
Is
is.
it AMH of 1? Is that a thing? AMH
Yeah.
of 1? And then it's hyphen. Is IVF even possible?
Yeah, sure. With an AMH, I mean, it depends on the unit. So there's a difference between picomoles per liter and nanograms per mil. But even with an AMH of 1, we've had people make 4 or 5 eggs. So yes, IVF is still possible. Remember, your AMH only predicts the number of eggs that you will make and how close you are to menopause. It does not predict success or failure for IVF. High AMHs can actually do very poorly because sometimes there's an egg quality problem, and low AMHs can sometimes do well, even though their AMH is low. So it does not predict success. It only predicts number of eggs and proximity to menopause. That's it.
Hello, Dr. V and Mr. T. Is it safe to do an IVIG for the first time in early pregnancy if I've never done it before? I have RPL and will try anything at this point, but worried about possible side effects and risks.
Safe if done carefully under the observation of a physician and a nursing team. Yes, it should be safe. Would I do IVIG based on just RPL? No, because you need to know what you're treating and you don't want to overtreat something because that by itself could be harmful. So I would never offer anybody an insanely expensive treatment like IVIG unless they actually knew that they needed IVIG. So if you know you need it based on your immune profile, different issue altogether. Talk to a competent fertility specialist who knows what they're doing with reproductive immunology, and we'll all be happy to help you. But if you are doing it just based on concern and history, that is not, in my opinion, an appropriate indication for someone to be doing IVIG. Don't want you to lose your pregnancy. You have to make your choice yourself. I'm certainly not telling you what to do. I'm just saying, in my opinion, I think you need evidence to use an expensive, invasive, not risky, but has side effects procedure like IVIG without actually knowing that you need IVIG.
Hello, doctor. What do you suggest progesterone levels should be on day 23?
On day 23, depending on how many eggs you've released, you're probably still looking, and assuming you're not pregnant, of course, you're probably still looking for something between sort of 5 to 20 as a reasonable level, maybe even higher sometimes. So that's kind of what we would be looking for. At a minimum, you want it, ideally, if you're aiming for pregnancy, you want it higher, but 5 to 20 if in a natural cycle, because it's already going to be coming down at that point.
Can calcium ionophore
Yeah.
benefit euploidy, or can it do more harm?
There's no evidence that ionophore activation impacts euploidy rates. There's also no evidence that it causes any harm. We use it routinely now for almost everybody with a low number of eggs. My team just does it, and we've had very good success with that. So that's why we're doing it.
If I will have a IUI, the doctors need to make some special tests before that?
Well, yeah, we need to investigate you and your partner thoroughly before we do IUI. We don't just do IUI. We need to know that you need IUI. So there are tests that need to be done first, for sure.
What can I do to increase my HCG levels 4 weeks?
Your HCG levels cannot be increased. They're dependent on your embryo and your age. It has nothing to do with anything you can do. So you cannot increase your HCG levels. It's a direct reflection of the cellular production from the embryo. So you can't increase that.
What are your thoughts on using? Suddenly it got all very small here. Northin's drone, 5 milligrams daily to suppress adenomyosis for 3 months.
No evidence. That's my thoughts. There's no evidence for that. So we don't do that. There's no evidence for norethindrone use independently prior to an FET that I am aware of. If there is, please shoot me the reference and I'll analyze it, but I'm not aware of anything. A lot of people have been asking about that because they want to use it with Lupron and letrozole to avoid the symptoms that they get with it. But there's no evidence for it, so I'm not willing to do that yet.
The Right Honorable T.
Oh, that's a good one. I like that.
I'll be honest, I flew to that one. That's like 4 comments ahead of us, but I said this is deserving of high mention.
Yeah.
And of course, Dr. V. What immunological and microbiome testing can your patients do in Canada? Fertility is the gold standard, but looking for a Canadian option for Ontario tax credit.
Right now, none. We'll probably be working on one in the future, but we're probably a little while away from that. None that I am aware of. I think there's a young lady, Genevieve, I forget her last name, in Quebec, who does something called Matrice, but I think that actually gets sent to France as well. I don't know of any that are in Canada that you can get tax credit for. Having said that, I guess if it was a huge problem and we can ask our accountants to look into it, I guess we could become the middlemen so that you pay us and we pay Fertility, if that helps you in some way. So I will ask our accounting team to look into that.
You just added some homework to yourself.
I did. Monique. Yeah. I'll have to, you got to remember to tell me to do that.
I'll make a note of it for sure. What is the ideal vitamin D in nanograms per mil for FET?
Oh, I don't know nanograms per mil for vitamin D. 75 nanomoles per liter. So do the conversion online, but you need a minimum of 75 nanomoles per liter.
Hi, Dr. V and Dr. T.
Oh, you love that.
I like that one.
Yeah.
It's good. This is an amazing human being here. I've been told I have chronic thin endometrial lining.
Yeah.
1 miscarriage, 3 rounds of egg retrieval with Menopur Gonalef, and 1 failed transfer, and my lining only got to a max of 5.8 millimeters. That's it.
So there are ways to thicken the lining. Uterine PRP, HGH, human growth hormone washes, Neupogen washes. You can do HGH injections. That's helpful as well. You can do vitamins A, C, D, E. All of those are helpful. Baby aspirin, vaginal Viagra, L-arginine, L-carnitine, pentoxifylline. There are a whole host of things. Plus, you can do a stimulation, low dose Gonal-F, 75 units a day. So there's many ways to do it. It's just a matter of which one you want to approach.
I got an email saying my first appointment is September 2nd. I'll be 21 weeks pregnant. Is that normal?
It has become harder for us to see people earlier because we have become quite busy. We are working on getting another person here. So once that person arrives, it'll be a lot easier. But at the moment, the backup is causing us to have to push some of the OBs back. So yes, it is normal right now.
What are ideal estrogen levels in early pregnancy, and would you ever use patches to supplement if found to be lower than expected? Thank you so much.
There is no ideal for estrogen levels in pregnancy, so ignore them completely. And that's been shown in studies looking at frozen embryo transfers, which demonstrate your estrogen level does not matter. So ignore your estrogen levels. You don't need to follow them. Would I ever use patches? No. You want to avoid estrogen in early pregnancy as much as possible because that's what actually causes inflammation and can actually trigger a much higher risk of preeclampsia, IUGR, things like that.
Hi, doctors. That's us.
I feel you, yeah.
Yeah. I'm taking Theralogix Neo Q10 because I read it's well absorbed.
It's very well absorbed.
The 125 milligram caps say they're equivalent to 300 to 600 milligrams of regular CoQ10.
That's right.
Do you recommend this brand? Also, any guidance on how many to take continued? What form of CoQ10 do you prefer for fertility support? Ubiquinone, ubiquinol, Neo Q10, etc. And What dosing do you typically recommend?
So we typically use any CoQ10. I'm not big on whether it's ubiquinone or ubiquinol. I don't really care, and I don't think it makes a difference. We did use NeoQ10, and I actually think NeoQ10 is a brilliant product. The guy that started it, I met him in California many, many years ago at a conference I was attending, and he had this great little display with a beaker of just water. And in one, he had a popsicle stick, and on the popsicle stick in this beaker of water was the Kirkland brand, like Costco brand, uh, CoQ10, and it just looked like chewing gum. And the watercolor was normal, and there was no absorption, nothing. And then in the other one was NeoQ10, and he would just fill it up with water and drop in a pill, and literally, like within 30 seconds, it had just dissolved, and it was floating around. The water was red. So we loved it. There were two very significant problems with it. Number one, it's made with this red dye, which caused at least 10% of our patients to react and come back with this horrible rash. And number two, it stank. Like it was unbearable. I don't know how people swallowed that pill. Now, I don't know if we had a bad batch and it got better or not, but I can just tell you our experience. So we stopped marketing it because of those reasons, but it is a great product and I have no questions in using it. So it is the best absorbed CoQ10 on the market for sure.
Hi, doctor. Today I'm on DPO3. I have been sebaceous infected cyst on my shoulder.
Sebaceous.
Sebaceous.
Yeah.
Yes. Sebaceous infected cyst on my shoulder in primary care. Doctor gave me methoxazole trimethoprim. Is this a joke?
Sulfamethoxazole trimethoprim.
Go for it.
It's actually the other way around though. It's trimethoprim sulfamethoxazole.
I had a hot dog for lunch, That's my maximum today. Which inhibits folic.
Yeah.
Can you help me with the alternative medicine?
No. So I wouldn't be able to provide you medical advice on a sebaceous cyst treatment that I've never seen before if you're not a patient. So you would need to talk to your doctor. Having said that, if you have an infected sebaceous cyst that someone's dug out of you, the inflammation in your body is sufficient that I would avoid attempting conception on that month. It likely wouldn't work. Now, if you're just having sex, that's fine because if it works, it works. If it doesn't, you had a good time. But if you're trying with fertility treatment, I would never allow that with our patients. We would hit the brakes.
Hello, Dr. VNT. What causes multiple back-to-back multiple miscarriages? One with no fetal pole naturally, then chemical, and one with fetal pole letrozole trigger shot. We even did prog. What am I doing wrong? I exercise 18/6 fast, walk 10K steps daily, and husband's SA was great too. PCOS, BMI 29, labs are okay, DHEA was 300, and other fun PCOS bundle. Fasting insulin was good. She continues to say, my doctor only wants to do IVF. She says that I'm just wasting my time. Otherwise, married for 4 years and still no baby. I'm 32. All my siblings have a soccer team of kids, and it's hard not to feel sad. Yeah.
So IVF won't solve your problem because you haven't figured out why you're miscarrying. So any doctor telling you that doesn't necessarily look at all the details, I guess. So first you need to figure out why you're miscarrying. So possibilities: shape of your uterus, polyps, fibroids, DNA fragmentation in your partner, smoking, drinking, drug use. Your BMI is not ideal, but we would never criticize your BMI at 29. So I don't think it has anything to do with that. Vitamins, your thyroid, we would look at carefully. We would definitely look at your microbiome and your immune system. And then some people need to, actually go further and do IVF in order to make embryos and do whole genome sequencing. But that would be like last resort for you. So first do all these other things, thrombophilia screen as well, before you go into anything else. And definitely do not do IVF until you know why you're miscarrying. If you can't find any reason why you're miscarrying, then yes, you do IVF. But if you can find something, fix that first and try again. You're obviously getting pregnant. IVF is not going to stop you from miscarrying. You're just going to miscarry a very expensive embryo. So that doesn't make any sense to me at all. And I would never endorse that. You should also get a karyotype to make sure you and your partner's genetics are normal.
Is there ever a time when they should just jump into IVF?
Yeah. I mean, if you've already failed a bunch of previous treatments, reasonable. If you've done 4 or 5 previous IUIs and you want to try another one and you're 40, that doesn't make sense. It's time to jump into IVF. If you've done, if you've had multiple miscarriages, you've done all the testing, it's all negative, you need PGTA to know if your embryos are normal. If you have a genetic abnormality, especially one that you need to avoid, like an autosomal dominant trait, or you and your partner are both carriers for cystic fibrosis or for sickle cell or something like that, any of those, Duchenne muscular dystrophy, yeah, because you can screen out the embryos that are going to be harmed. So there are some indications. They're not a lot, but there are some. I guess the only other large group would be women who are older and need an egg donor, because there is no way to do it without doing IVF.
Doctors, what are your opinion on Pregmune for immune testing instead of Fertility? It can be slightly faster to get results back and cheaper if insurance covers it. So curious if you accept it.
I love Pregmune. Pregmune's amazing. Like, I got nothing against Pregmune. It's a great product. The reports are super detailed. I just read one yesterday, in fact. Pregmune is great. The problem with Pregmune is the testing is 10 grand and the report is 3. Now, if you have insurance that covers it, go for it. Of course, I got no argument against it. But telling my patients to spend 13,000 US dollars instead of spending whatever it is, 12, 1500. I mean, it just doesn't make sense, right? So we use Fertility because traditionally they're cheaper. But if you have coverage, yeah, of course, use Pregmune. I got no qualms with that whatsoever.
Howdy, docs. Do you work with an acupuncturist in or near your clinic? I'd love to connect with you when I come to Windsor.
Yeah, we do. Our naturopath does acupuncture just in the office, literally next door to us here. So yeah, you can go there. Jen Strong, she provides it. We actually work with people that do acupuncture in each of our clinics. So we have one in St. Catharines, we have one in Sarnia, and soon Woodstock as well.
From TikTok, still going strong.
I love it.
See, that's they wanted it this way.
And thank you to the people watching on TikTok, because you've really helped grow our program, and our numbers on TikTok just keep going up and up and up. So thank you, TikTokers. We should actually do like a TikTok special.
A salute to TikTokers.
A salute to TikTokers.
Yeah. 27, had one failed IVF transfer, found I have endo, did a lap, and now second transfer. Is there a chance?
Oh, there's totally a chance, but make sure they're using a dedicated endo protocol, not the here's your estrogen, here's your progesterone, good luck protocol. That doesn't work. But using a dedicated endo protocol, you have very good chances. And we have one, and it's available on our YouTube. You can just look it up.
Does PCOS increase the possibility of a miscarriage?
If you believe the research, yes, it does.
I've had my tubes tied for 16 years. What are the chances if I get them untied to get pregnant?
Wow. Okay. So there's a lot to unpack there. So if you had them tied for 16 years, unless you were 21, 22 when you tied them, which I find unlikely, but who knows, then your chances would likely be low because you're in your 40s. If you are not in your 40s and you're still in your 30s, I want to know what doctor tied your tubes that early, because that would be very early. But you would have a reasonable chance if you're younger. If you're older, your chances have nothing to do with the tubes. We can successfully flip the tubes back together. The problem is you're older and your chances of getting pregnant are lower.
I wanted to say something on the tube comment.
Okay.
So you tie the tubes because my understanding, and again, this is not a quote unquote doctor's understanding. This
Yeah.
is just that there's two ways to tie tubes. There's a permanent tube tie and a lesser permanent tube tie. At least this is what I recall when I was much younger.
Okay.
My question to you is there even such a thing as this? And then second, let's say you are like in your 30s.
Yeah.
And you want to undo your tube tie. You had like 2 kids, or like, well, this is a zoo, tie them up, don't want any more kids.
Yeah.
Now you see everybody's got little babies, and like, you know what, I want more tube. Like, is that a thing? You go in there, you open them up, kids back to normal, or is it very stressful and exhausting and evasive? And like, what's the story here? What is the tube untying story?
Okay, so tying your tubes, there's like 4 different ways.
Oh.
So the main way we do it now is we actually remove the fallopian tube. We take the whole thing out. And the reason for that is it reduces your risks of developing fallopian tube and ovarian cancer. So you're 38, 40, whatever, you had your last child, you want your tube out, very reasonable because we're reducing your cancer risk. If you're younger and you're thinking about tying your tubes, but you're not sure, for the love of God, don't tie your tubes. Get a Mirena IUD. You pop in the IUD, it takes away your period, it takes away pain, and it's as effective as tying your tube. So that's a total no-brainer, right? If you're tying your tubes for whatever reason, there's a clip. It's called a Filshie clip, which is amazing, but it became super expensive, so everybody abandoned it. There's something called a silastic ring, which is this like rubber donut that wraps, you have to kind of knuckle the tube and it wraps around the knuckle and pinches it off on the 2 sides. So you get like an eyelet like that. And so that has been used. I haven't used it since residency, and only one guy I knew then did it, but he did it fairly successfully. It was easy to use. And then the third way to do it is to actually stitch the tube closed. If you're stitching it closed, or you're using the silastic ring, or you burn it, you can also burn it. Putting it back together is very difficult because you're damaging a lot of tube. And when you go to put the tube back together, you got to cut out around the damaged part and then pull the tube. And if the ovary's here and the end of the tube is normally here, when you cut out that much, you're pulling it away from the ovary. So now it can't grab the eggs as easily as it did before. And you could actually be doing something completely useless. If they've put the clip on, which we see less and less of now, unfortunately, that's easy to fix. You cut around the clip, which is really narrow. It's like 5 millimeters, and you just sew the tube back together, and those patients do great. So it all depends on what they had done before. Is putting it back together invasive? Yes, it's invasive. We have to do a mini laparotomy. I got to stand with this giant microscope over a patient's belly, or loops, which I bought during the pandemic. And I got to stand there and I got to do the work. And the stitch is 8.0. It's thinner by probably 80% than a hair strand.
Oh, wow.
Like you can't see it unless you're looking through the microscope. It's hard to work with because that's what we're using to tie the tube back.
Yeah, you're already working with, inside a human being. It's already small enough.
It's super challenging surgery. Super challenging. And the stitch has a mind of its own. You put it here, it goes there.
Yeah, it's like the video camera when you're trying to adjust it. You don't know where it's going.
Yeah.
Oh, wow. Who knew?
There you go.
So when someone says they tied their tubes, that doesn't really narrow it down to what they actually did.
No. Burn, suture, silastic ring, Filshie clip, remove.
And how do you know? Like how do
you got to read the operative report.
Oh, you got to read the operative report.
Because then we have to dictate, I did this.
Oh, I see. Everybody has an operative report?
I sure as hell hope so.
Oh, wow. Interesting. See, everybody learns on this show, guys. Even Dr. T learns. All right, back to TikTok.
You got to put the camera back on you.
It doesn't matter on TikTok, but I'll bring it back on me.
Good point.
Yeah.
Good point. I guess it'd be on me. Yeah,
it's on you all day, man.
It's on me the whole time.
For TikTok anyway.
You're back off the camera.
I got a minute. I could just breathe a little bit.
Well,
What?
then you need to put it back on.
Yeah, but
Oh,
for
for TikTok, it
for
won't
the
matter.
TikTok and YouTube and all our other friends, hello, I'm here. Don't worry, guys. What is naltrexone used for in an FET? It was added to my immune protocol at the last minute.
Yeah, now Trexone is used in an FET protocol because people are trying to throw spaghetti at the wall and hope that it sticks. Zero evidence, zero. There is no evidence for the use of naltrexone in anything related to infertility other than one study looking at PCOS women in which it showed a very subtle, additive effect that was beneficial, very subtle. And it wasn't a great study. There is zero evidence for using naltrexone, none. It was popularized by a well-known three-letter clinic that provides very inexpensive IVF services. And they may be aware of evidence I am not. And if they are, I wish they'd share it. But I've looked it up many, many, many times. There is nothing out there that suggests that naltrexone is beneficial. So I don't use it yet.
What's the success rate for euploid day 7 embryos?
15%.
Hello, Dr. Victory. Thank you for helping us bring Blake into the world.
Oh, that's so cute. Thank you.
27, had one failed IVF transfer, found I have endo, did a lap, and now second transfer. Is there a chance?
She already asked.
She did that, yeah.
Yeah.
I have 2 times for 16 years. Dr. Victory, what do you think of 4BC embryo?
Good embryo, not like the best, but usable. No reason not to use that embryo. That's a reasonable embryo.
Howdy, docs. Do you work with an actual? Oh, we did that as well. One more question. Is dental work cleaning with or without fluoride safe in early pregnancy? I did an oral microbiome test and some bacteria found can supposedly lead to a miscarriage. Any safe supplements?
Well, lots of supplements are safe. Just don't let them dig into your gums. Bacteria in your mouth can very quickly get into your bloodstream and cause a miscarriage. And there is good data. We actually did a Instagram post on this, which I was shocked. I thought would totally go viral, and
Yeah,
it didn't.
Yeah, I noticed that too.
You know, we should redo that one.
Just put it up again.
Put it up again.
All right.
We should. So I thought that would go viral, but there's no question that people with bad oral hygiene have much higher risks of pregnancy complications. And people that are getting their teeth cleaned also have pregnancy complications if they dig into your gums. So you do want to be cautious or take antibiotics.
Does endo always mean immune issues?
Yes. Always.
After 2 failed FETs with euploid embryos, I did the Emma and Alice biopsy. It found that I had no lactobacillus. I treated that with 30 days of suppository probiotics, NFH, and oral probiotics. Transferred my final embryo, which was a LLM, and had a chemical pregnancy. I was also on Fragmin, Medrol 5 days, and prednisone after Medrol. I'm waiting on a consult with you. Should I do Fertility while I wait? Did you say to ask for Dr. Victory panel 2? I'll be coming with my file from my previous clinic. Anything I can do so I don't have to wait 3 months for a second appointment?
You can do your fertility test. For what you're describing, you probably only need Victory Panel 1, which is their microbiome and their full immune panel without KIR. And we normally only do the KIR for people with recurrent miscarriages. So if you've only had one, I would say not to worry about that. I don't believe in Emma and Alice. I don't think it's a good test. Not to mention, I hate biopsying women. It's savage. So we don't do that. And we don't endorse Emma Alice testing because the company, and I have it in their email, so I can share this publicly, claims that 20% of women have a sterile uterine environment, which is, in my opinion, not true. So we don't use their test. We use Fertility instead until somebody makes a better alternative. So I love their test from Fertility. It's accurate. It helps us, and we know what to treat. Is taking a probiotic sufficient when you have no lactobacillus? No. The question is, why do you have no lactobacillus? Something is always taking up that space. It's not like there's no bacteria there. There's got to be bad bacteria there if you have no lactobacillus. So simply taking probiotics to give you more lactobacillus actually does nothing, because bad bacteria don't go away just because you flooded a whole bunch of good bacteria in there. So that won't work. And that might be why your low level mosaic unfortunately became a chemical when it should have had a pretty decent chance. So I'm not a believer in Alice.
So I'm on cycle day 11. When's the best time to do the deed? 28-day cycle generally on letrozole, and finished day 5 yesterday. I'm 45.
Every day from now till day 17.
It's good advice.
Self-serving, maybe, but yeah.
Good advice.
Every
Overall,
day
good
from
advice.
every day from now till day 16, 17 would be reasonable. The last couple are probably not of any value, because once you pass the day of ovulation, it's a 0% chance. But you don't know exactly when you're going to ovulate. So like a little bit of a buffer zone in there is reasonable. But every day or every other day between now and ovulation is your best chance.
What kind of pain management strategies do you offer for patients with medical anxiety?
Anxiolytics, benzodiazepines, acupuncture, stress reduction, meet with our naturopath, humor. I'm always trying to make people laugh in the OR. We hold your hand. I just had a patient today that thanked us profusely because I held her hand when she goes to sleep for a surgical procedure I had to do for her. And, just little comforts like that, it makes all the difference for people. So anything we can do to make you comfortable, we will. We play music. Most of us dance, sing. Maybe not during procedures. I'll sing during procedures.
You'll sing, give a nice little song.
I'll do a Teddy Swims during during an egg retrieval. Yeah.
Dr. VNT.
Yeah.
Question for all the single ladies.
All the single ladies. All the single ladies.
Which part of the immune testing and treatments are dependent on having access to the sperm provider?
DQ alpha, KIR, and your LAD test. The rest are not. Your NK, Treg, cytokines, and NK cytotoxicity don't need your partner or a partner.
Do men with celiac disease typically have more fertility issues?
Do we start the PhD fertility show? Tonight's question.
It got hardcore, right?
Yeah.
I'm actually looking at you saying, you better be ready, man. I'm trying to give you the signal. I'm like, hey, Ryan, they brought their A game. They watched the last month worth of episodes.
I'm getting grilled over here. Do men with celiac disease have more infertility? Probably, because their gut microbiome can be disturbed, and that has a very significant impact on every aspect of reproduction. But I'm not aware of data. If Cindy's watching, Cindy would probably know. So Cindy, if you're watching, jump on the show and tell us.
Any opinion on bed rest after an FET?
Yeah. So there's a study from California that showed that bed rest was not only not helpful, it was actually potentially harmful compared to going back to work. However, before everybody freaks out about that, we believe that it's in your best interest to do whatever relaxes you the most. It's not bed rest or no bed rest. It's just keeping you calm, happy, in a good frame of mind. If you go home 10 minutes after your FET and you're looking up every symptom someone has 10 minutes after an FET, it's not going to work, because you're so anxious. All your stress hormones are running wild. You're not going to help the environment for that embryo. If you're back at work and you're distracted and you're just doing your thing, your chances are going to be better. Now, if you go to work and your work involves stress, that's probably not a good thing. So go home, sit on the couch, Do not go on your cell phone and look up every single symptom that could be possible 10 minutes after an FET, because there are none, zero. You will not know if it's implanted or not. So just stay off your phone, read a book, play a game, watch a movie that's funny, do something entertaining, but, bake some brownies, bring them for me, of course. But, oh, and thank you, Heather. World-class brownies. Love them. My son, Nassim, if you ate my brownies, I will kill you. Yeah, like just do whatever you enjoy. Keep the stress level low. That's the goal. It's actually the same thing with acupuncture. Nobody's sure that acupuncture is beneficial for IVF. A lot of studies, some positive, some negative. No one knows. So the current prevailing theory is if it relaxes you, do it. If it doesn't relax you or you're cringing when they're jabbing the needles in you, don't do it, because it's not going to be helpful and it could be harmful.
If I will have a IUI, one of my tubes are closed, the doctors need to do tests to see what's wrong with my body DDORS. My body. I don't know. We'll go to the next one. I don't know.
No clue. Sorry, didn't understand that one. By the way, I feel very naked because I didn't bring my watch. I have no idea what time it is. And you've got my phone.
8:51, sir.
Really?
Yes.
Wow, that flew by.
Oh, yeah. You are getting grilled, sir. Absolutely.
I did get grilled tonight. It was like PhD fertility factor.
It keeps going. It keeps going. Hi, Dr. V. I am actually, to read this correctly.
Yeah.
Hi, Dr. V. And T.
Okay.
That was important to
You
put
got
in
it
there.
all.
Yeah.
Yeah.
I'm 40
Okay.
years old
Okay.
with DOR.
Okay.
Husband has poor morphology. I usually get 2 to 7 eggs per ER, nor euploids. Average fertilization is 73%. Can we consider calcium ionophore?
Can you? You should, for sure. I would want to know why you're getting no euploids. 5 rounds of that number of eggs, you should have had at least a couple by now. So maybe before you do any more, chat with me so that I can help you. It's not just about doing calcium ionophore. Improving your egg quality before you start can make a difference. Your stim protocol can make a difference. Your priming can make a difference. Your trigger will make a huge difference. So there's a lot of different things we can do for you that would help you. Contact me before you do more.
A mysterious question.
A mysterious question.
Do you make money when patients get the victory package from Fertilisys?
Absolutely zero. I have no financial involvement with Fertilisys whatsoever at all. In fact, I always jokingly say that when we get together for dinner, and they've been very gracious, so they've picked up the tab sometimes, but I think I've actually paid for more dinners than they have now, including the most recent one we had together in London. We are friends. I love them dearly. We make a couple of video clips together. I'll lean on Dr. V to get his opinion on something, or to ask him to speed something up, or occasionally do me a favor here and there. I have zero financial involvement from them. In fact, the victory panel is called the victory panel because I made Fertilisys give you a discount. I don't get a penny from it, not one. And I am so happy that you asked that question. I would literally be willing to, have you ask Fertilisys, show you you can talk to our controller. I got nothing to hide. Like, we don't make money from that kind of thing because I think that would be unethical. So we're not doing that.
Would a progesterone level 39.1 on cycle day 23 be of any concern, assuming the female is not pregnant?
No, you probably just had strong eggs. There's nothing wrong with that.
Oof, good thing I found this one. Dr. V and honorary Dr. T.
Anything that starts with oof, I'm nervous, right?
Like, no. It's usually just about me, to be honest. It's got nothing for you to worry about.
Yeah.
So when you do have to worry is when I actually look concerned.
Oh, I know. I'm
okay.
I'm paying attention.
Yeah. So this one, I don't even know, but I just saw honorary Dr. T and I just jumped at it. How was it determined that complex, abnormal embryos are sometimes a mistake in the test and actual normal? And how often do you find this in the case? Any studies?
There are two studies now. One showed a lower rate than the first one did. The first one said that out of 30% of the embryos they retested, 10% came back normal, which isn't super high, but it's still pretty reasonable. We actually sent 6 embryos and 2 or 3 of them came back normal. I think it was 3. So how do you determine it? Well, technically speaking, the best way to determine it is to send in the embryos for testing to see what they come back with. And if they come back as being, basically normal, then that's great. But now what you've done is frozen your embryos when you first made them, biopsied them, froze them, right? So that's step one. Then you thawed them, rebiopsied them because you had to do it again. Then you refroze them. And then if they're normal, then you're rethawing them. So there's a very well-known clinic in Ontario that believes that and actually promotes the fact that they've done this many times in their own program and it has no harm. But if you look at the published data, it's very clear that it is very harmful. It reduces your success rates by 30%. So with that in mind, what you really need to ask is what's the best approach to this? And my advice would be, number one, have a long talk with your RE. Number two, have a very long talk with a geneticist. And then third, have a talk with a counselor and then just go ahead and transfer the embryo. Because if it's going to be normal, it's going to work. And if it's complex abnormal and it's actually complex abnormal, there's no way those embryos are going to take. Even if they do, you have the option of doing a termination. So as long as you are comfortable with the genetic termination of a non-viable or highly abnormal fetus, which is not for everybody, then I would go ahead and transfer those embryos. If it works, it works. If it doesn't, it was abnormal. But the only other way is to actually thaw them, rebiopsy them, refreeze them, rethaw them again if they're usable. 30% decrease in success. I don't recommend that.
What are your thoughts on letrozole?
It's a big, broad question. So we use letrozole for PCOS patients. It has the highest success rate compared to Clomid, 27.5 versus 19.1 for Clomid. So that can be used. That's for live birth over 6 months of use. We use letrozole as part of our endometriosis protocol and for some of our endometriosis patients for STIM. We use letrozole as part of every frozen embryo transfer protocol because it's been proven to be beneficial and have a better success rate. So we use letrozole a lot, but it depends on the indication and it depends on what you're aiming for.
Docs, can you elaborate on how vitamins can be more harm than good? Saw it on your most recent video.
So most vitamins fall into the class of being antioxidants. Oxidation is when something called a reactive oxygen species, which is an oxygen molecule with one of its electrons ripped off, runs around trying to grab another electron because it wants to go back to its native state. In the process of doing that, it's plucking electrons from all sorts of other molecules, which then damages those. And that process is called oxidation. So vitamins are scavengers for those reactive oxygen species and bind them up and stop them. So it's kind of like putting a cage around the Tasmanian devil. That's what a vitamin does. Tasmanian devil's whirling around, doing damage to everything, causing chaos. And then you slam a cage around it and stop it from moving. And that's what a vitamin does. If you take too many vitamins, however, and I don't know what the right analogy for this would be, but you've put so many cages in place, there's no room for any normal activity. So it's not just that the Tasmanian devils are all bound up, they are, but now there's no room for anything to happen. Nothing grows, nothing, there's no sunlight getting through because there's just too many cages. So that's not good either. And that causes what's called reductive damage. And we know, at least in sperm, and I'm not aware of any egg-based data, but we know it's going to be the same. That in sperm, you can actually have reductive damage. So we get a lot of women that have their partners on like 15 different vitamins. Yeah, that's not good. You're probably doing reductive damage. The good news, we actually have the device to measure it. So you can just come here and we do it. And it's like 150 or 200 bucks or something.
9 o'clock.
Tarek's terminal question.
Wow, the pressure is on.
Because I got to go home and pack for Chicago.
Yeah.
And see my baby.
Let's go on to. We'll go to YouTube. We're going to pull a question off of YouTube.
Sure. I love YouTube.
Oh, you know what? Here we go. What would you tell your patients with an autoimmune condition over 44 for IVF with an AMH of 0.2, all blood work normal except for testosterone supplementation with 25 milligrams of DHEA, planning for PRP? What would you tell them?
PRP is useless. It will not help you because your problem is genetics. It's not egg number. So I would tell you, save your money and not do PRP. It's completely useless in that age group. There is no evidence that it benefits those women at all anywhere. So, and don't believe the hype. It's just hype. Just do the math for yourself. At 44, somewhere between 90 to 95% of your embryos will be genetically not normal. And PRP absolutely will not fix that under any circumstances whatsoever. So you need somewhere between 10 to 20 blastocyst embryos to get one that's normal, which means you need somewhere between 20 to 40 eggs to begin with. Doing PRP is going to make you make 1 or 2 extra eggs. Who cares? Like, sure, it's going to cut down by 1 out of 5 cycles. You may only need 4 instead of 5, but you still need a ton of IVF cycles to get the right number of eggs. So PRP by itself is going to be useless. With that AMH as well, you're only making 1 or 2 eggs, if even that, in which case you actually will need to do somewhere between 10 to 20 rounds of IVF, which is illogical. So the very first thing I would tell you is do not fall prey to anybody telling you to do PRP. That's a total waste of your money. The second thing I would tell you is that there is no single protocol that would be beneficial for you. In fact, if anything may work, huge may, it's actually going to be the in vitro maturation protocol we're working on. And we won't know for a little while, but that's something that may be beneficial for you. Aside from that, you're basically looking at either just try natural cycles and see what you get, or get an egg donor. But PRP will not help you under any circumstances. Zero.
I think that's good, right? Terminal question. That's what you said.
That was a great terminal question.
Yeah, I thought that was good.
It was very good. All right. So you all have yourselves a lovely evening. We are signing off because I got to pack for the Midwest Reproductive Symposium tomorrow. Tomorrow night we're going, and I got to go home to see Jenna, who I love more than anything in the whole world, except for my 2 boys and my wife. I love them too. So you all have a great evening. We will see you next Tuesday on Fertility Factor Fiction.